Good morning. It's very nice to be here with all of you. As you heard, my talk today is basically be on Resident Autonomy. It's entitled Trust Me. I am just learning while practicing while teaching. Is Resident Autonomy a realistic goal? And as more and more people come in, I'd encourage you just please come on down to the front. I'm not sure about the culture here, but again, I'm short, so to keep looking up like this is going to bother my neck. So if you guys wouldn't mind coming down. I'm especially grateful to be here given the beautiful weather that Boston has enjoyed over the last 3 weeks. As you probably heard, we're having our fourth blizzard coming up tomorrow, actually, so you may see me tomorrow again here. But it also was the first time I've ever even heard of the term bomb cyclone, which evidently is a real thing, and has happened not once but 3 times in the last 3 weeks. I have no disclosures other than my last name is not nearly as difficult to say as people think it is. You think of a table, you think of a yak, and you say, wow, that table is big enough to fit a yak on. Phitayakorn is my last name, in case you guys need it. So worst case today, you can say you at least learned something from this talk. And my experience in med-ed, as Dr. Lau mentioned, is that I basically am a little different than your average education researcher. I have a 50% clinical practice in both general surgery and endocrine surgery. I take about 4 to 6 weeks of general surgery call a year, and I cover about 17 general surgeons when I do take call. So it's pretty busy. I also used to be an education consultant for our partners GME office, and that was specifically to design curricula and assessment tools for program directors and fellowship directors. I was also our surgical lead for our simulation center for 4 years, where I did a lot of team training with some of our old residents and attendings and nurses and surgical techs. I also, as you heard, I'm the director of medical student education, so I oversee 2 clerkship directors and 6 associate clerkship directors. I'm also the chair of the HMS Surgery Clerkship Committee, so I oversee all surgery work at the Harvard teaching hospitals, which is a lot of meetings, in case you're wondering. And finally, in the last 50%, which I don't think adds up to 100, I am the education technology consultant for the New England Journal of Medicine. And specifically there, I basically research learning technologies and look at them for either collaboration or acquisition. And then, like all of you, in my spare time, I teach at all sorts of levels in medical education spectrum. Now, I realize, as Jim mentioned, that resident autonomy is a controversial topic. At least it is where I'm from. I trust it's probably the same here. I received an email from Jim about 9 months ago asking me if I would be available to speak today. I said absolutely, I'd be honored, and I sent him a list of grand rounds that I've given and workshops and things like that. And he said, well, it'd be really great if you could do resident autonomy. And I emailed him back and I said, that actually wasn't on the list that I had sent you already, and it's very controversial. And he said, no, but I really would like to hear about it, and I think our department would really like to hear about it. And then I thought, well, I thought we were friends, but okay, fine. So I recognize that, in this kind of mixed audience, some of you may have very strong feelings about this. But again, I just hope we can have just an open and honest conversation about this very important topic. And specifically, we're going to talk about the educational theories behind resident autonomy. This is where I lose usually about 50% of the audience due to boredom. So we're going to quickly transition, and we're going to talk about the current state of resident autonomy. We're going to discuss some of innovations that we have done around this topic, and then debate the future of resident autonomy. So the word autonomy is actually from the Greek word autonomia, basically meaning having its own laws. And in an educational context, a common definition is really the drive to be the origin of one's behavior and to exercise free will in choosing one's goals. And we know this is really important because autonomy is just one of the key ingredients of what's called self-determination theory. Come in. At any rate, and basically it's this idea that autonomy combined with competence, which is basically the need to feel efficacious in the actions that one does, combined with relatedness, which is the desire to feel connected with others and valued by a community, basically equals a happy, independent physician, right? And really allows someone then to understand the role they fulfill within their community. And although this talk is on autonomy and not physician well-being, I would argue that loss or perceived loss in any of these domains ultimately results in burnout and depression. Now, we know that adults, at least most adults, learn best when they are intrinsically motivated, self-directed, can build on previous learning experiences, immediately apply that learning to something, and typically prefer mixed learning styles or methods. And autonomy really relates with adult learning theory in that it basically integrates with intrinsic motivation and self-direction. So if you take all of these theories, right, and you review the non-medical education literature, it is very clear, okay, that increased autonomy has been proven to result in increased motivation, increased learning and retention, increased satisfaction and happiness, and increased achievement. So you may be thinking, why have this talk today if autonomy is so great? Well, if you look at the medical education literature, it's the complete opposite. In fact, the discussion of resident autonomy is often filled with this kind of tension that builds between resident physicians and attending physicians, right? Where, and this is all specialties, not just surgery, where autonomy is essentially this rope that you see going back and forth. And attendings feel they must control it extremely carefully, and residents are portrayed as wanting as much and as quickly as possible, right? Why is this? Well, I would argue that in the last 20 years, we have seen a gradual loss of resident autonomy for a wide variety of reasons. Number one, new procedures, right? With the advent of laparoscopic and robotic procedures, we have over 100 new operations. Without clear guidance on how much proficiency in each of these procedures the average general surgeon is expected to have without fellowship training. There is also a much heightened fear of malpractice litigation. In fact, with social media, a few unhappy patients can essentially destroy a surgeon's reputation. Operations are also significantly more complex. There is more and more chronic disease, especially at academic medical centers, right? So for example, it's not the patient who comes in with the straightforward inguinal hernia. It's the patient who comes in with the inguinal hernia but has also had a heart transplant, is on 2 antiplatelet drugs, right? It's a little bit more challenging, and again, maybe you'd be a little bit less reluctant to give resident autonomy. And then finally, there's a general loss of index cases. This has been shown over and over again. It's not just the 80-hour work week. I think it's also this idea that a lot of things that we used to manage operatively honestly just aren't anymore, right? We're managing even traumas non-operatively. So again, more and more operations I think are going away, and residents therefore get to do less and less. So we're going to transition now and look at the current perspectives on resident autonomy kind of from a multifocal lens, kind of like this cute little insect over here. And we're going to kind of delve into each of these, but obviously if you want to talk about anything more in detail, let us know. So starting with the medical student frame, the medical student perspective on resident autonomy is a little scary, right? Basically, as we've seen resident autonomy go down, there is a trickle-down effect to the medical students, right? Medical students, as you guys know, are generally being left behind. They're basically being ignored. And they're allowed to do less and less in turn as well. In some places, they're not allowed to write notes anymore. They're not allowed to place orders. There's restrictions on the types of procedures they can help with or do. Sometimes they're not even allowed to observe, like child delivery, for example. Patients can say, no med student, and that has to be okay, right? And so med students are basically kicked out of the room. And it's really, I think, a shame because, again, this talk is on resident autonomy, not medical student autonomy. But the bottom line is, as you all know, medical students are our supply chain, right? And as medical students see the autonomy of residents going down and down and down, I think it naturally kind of taints their opinion of that specialty because they know ultimately they're going to be that same resident. In fact, at least at Mass General, we're having a lot more applicants now coming in asking about resident autonomy when they interview. And I think this is a major reason for it. Now, if we focus on the resident perspective, this is the audience participation part. So for all of the residents in the room, okay, I totally get that this may not feel like the safest space to talk about resident autonomy in front of all your attendings who evaluate you, okay? Again, I just want to have a conversation. I think it would be helpful, it would be useful, right? But I'm not trying to force you to do anything you don't want to do, okay? So, no pressure, right? But if you wouldn't mind, okay, all the residents in the room, if you could just raise your hand. Good, so almost half. Okay, good. So just keep your hands up for a second, okay? They really just need to come in. I don't know. So at any rate, just keep your hands raised, okay? And now remember, for the attendings, I know you're going to want to say something here, okay? But remember, your part is coming up in 3 slides, okay? So just give it a second, all right? Now the residents in the room, okay? How many of you feel like you have enough autonomy in this program taking care of patients pre-operatively? Keep your hands up. Okay, hands back up again. How many of you feel like you have enough autonomy post-operatively? Okay, now the million-dollar question. How many of you feel like you have enough autonomy intraoperatively? About half the hands went down. All right. Does anybody feel comfortable talking about that?
Yeah, I think that
Round of applause for him.
Yeah, I think in our residency, over time, autonomy picks up. And so I think what you see as a junior resident is not what you see as a senior resident. And it's one of those things that the better you are, the more autonomy that you get. And I think with the vantage point that I have now, being close to graduating, I think that I've seen autonomy increase considerably. But it's not what I wanted when I was a 1, 2, or sometimes a 3.
Mm-hmm. So you kind of see then, and I'm not trying to put words in your mouth, but you kind of see then, if the attending gives you more autonomy, they're like saying, you're doing a good job, right? Like you're competent. So I'm going to give you more autonomy. Yeah.
I think autonomy also comes in different forms. You don't have to be alone in the room operating to be given autonomy. You can help make decisions during a case and move a case forward and affect what you do without being alone. And I think those are in some ways the times when I feel like I've come the farthest is when my attending that I'm operating with actually listens to my opinion and it affects what we do. So in that regard, I think autonomy doesn't necessarily mean you're alone. It means you're an active participant in thinking and helping make decisions.
Excellent. Excellent. So that really highlights the intraoperative decision-making piece. That's great. Any other comments? Yeah, in the back.
So we work at a lot of different sites, and I think that the autonomy is very different sites. So at one of the private institutions we work at, they have a lot of time limits on what they can do, and they have rules about how many attendings have to be present, how many cases they have to do, and so our autonomy is definitely less there. And then we have other sites where it's like, go do this case and take a junior resident with you. So I think we have different opportunities for autonomy in different places we train.
Mm-hmm. That's great. Yeah.
Before med school, I was a teacher, and one of the things that was important in teaching was giving the opportunity for our students to demonstrate their mastery of every skill. And we didn't consider them mastering that concept until they'd done that. And if they failed, we had to provide another opportunity for them to demonstrate that. I think as a resident, a lot of times we participate in cases and we're going to have more opportunities to demonstrate something. We're just not given that opportunity, or that discussion's we never have a discussion about what part of the operation we'd like to have some autonomy with. And we may, participate in it and be and throw a stitch for the attending once, but potentially, we'd like to place retractors or do something different, but there's no discussion about what part of that case could provide some autonomy.
Yeah.
This is a junior resident, something that I'm wanting to develop some
Sure.
sooner.
So not to put you on the spot, and obviously any of your colleagues can chime in, but what do you think are the barriers to that communication happening, right? That checking in with the attending about what part of the operation, maybe you want to do a little more of, that sort of thing.
I think barrier is maybe the frequency of doing a given operation with a certain attending. Sometimes we work with a lot of different teams and maybe we haven't developed a relationship and it's kind of like our one time and we don't want to step outside of our social bounds and demand something if it's one of the first times we've operated with them.
Yeah. No, absolutely, right. So this relationship piece is really important. And interestingly, your GME office has tried to actually develop protocols in place to try and overcome, right, some of those relationship issues. And I just show you this. So according to your Stanford GME office, you have 3 levels of supervision here. So basically you have a level 1, which is direct supervision, so the attending is literally standing there with you in the operating room. You have a level 2A where the attending is immediately available, right? So maybe they're in the operating room but not scrubbed, or maybe they're like in their office or something like that nearby. You have a level 2B where basically the attending is at home or something, but they are available by phone, and if you get into problems, they can immediately come in to the hospital. And then you have level 3, which I guess is kind of like see you later. We'll talk about it sometime in the next couple weeks, and I'll give you some feedback, okay? So based on those 3 levels, they split up the operation and said basically a PGY2 in this general surgery residency program is allowed to position, prepare a case, close skin, and transport the patient with the attending being at home. And a PGY4 is allowed to start a case, both scheduled and emergency, and put on abdominal wound closure device without the attending even being present in the hospital. Accurate? This is from your own GME office. I didn't make this up.
That is not how we do things.
Can you elaborate?
Yeah, sure, there are some of those things that we do as 2s and 4s and 5s, but the routine is not that a PGY4 is starting a scheduled but a case with the attending at home. Does it happen occasionally that as chiefs we start scheduled cases while the attending is on their way? Yeah, but that is not the routine expectation. And I would say most of our attendings are physically present in the room or chatting outside the OR door when we're operating on our own.
Right, and so I think it gets back to the first comment that was made, is that what we'd like to see is this kind of gradual increase in autonomy, right, as the residency goes on, right? But the junior residents, right, the PGY2 level, would like to have some autonomy of their own. But oftentimes there's a disconnect, right, between what people say is happening and what is actually happening within the program. And so, this is obviously not an isolated case, right? So they did what's called the Procedural Learning and Safety Collaborative, did an enormous study of this where they looked at 14 general surgery residency programs, and 444 attendings completed over 10,000 simple procedure evaluations on 536 categorical residents, okay? And what they found is that only about 33% of the residents in the last 6 months of their training were able to achieve supervision only, right, which is essentially near independence, in the core operations, or the ones that happen most often, of cholecystectomy, hernia repair, appendectomy, and partial colectomy. Now, some of you in the audience may be shocked, right? You're thinking, oh my goodness, 33% can't do these basic operations as they're getting ready to graduate. Other people in the audience are saying, oh, that's fine. I mean, as long as these 30% are going to go on and do fellowship and aren't going to be on their own, in the middle of rural United States somewhere, then that's okay, right? But again, this is where the conversation has to happen. This is where we need, as a specialty, to try and come together and decide what's best. Because the bottom line is that among all of us, there is a feeling that as the residents have decreased autonomy, that ultimately this leads to decreased confidence and the need then, therefore, for fellowship training and decreased competence. And if you look at the literature, this connection has actually never been proven. But we all feel it, right? And we all worry about it. We talk about it in the break room. We talk about it in the lounge all the time, right? And we complain bitterly about this. But what are the other perspectives? So let's look at the attending surgeon. So again now, audience participation part. All the attendings, would you mind raising your hand? Great, okay. So first question, okay. Do you allow resident physicians to do parts of an operation when you are not in the operating room? Keep your hands up. Okay, good. So that's almost all of you. All right. Next question. Do you explicitly tell patients what the resident will be doing in that operation? Okay, about half went down. Okay. So of the people who are still raising your hand, again, if you don't mind sharing, okay, if the patient asks you, what will the resident be doing in this operation, what do you tell them? Sir.
I mean, I have, the most common thing I ask about are lab codes.
Yeah.
I actually cannot stand on the left side of the table anymore. If I try to do a lab code, it's embarrassing. So, so even with the worst resident, I'm better on the right-hand side of the table than I am on the left. So I tell the residents it's an orchestra. I can't play every instrument, but I'll conduct it, and it'll happen the way I want it to happen.
Right, so not to put you on the spot, but if the patient asks you, what will this resident be doing in my lap chole? You mean you're saying that you're telling them this resident's going to dissect out the ducts, clip everything, get your gallbladder out?
Yeah, exactly how I want them to do it.
Right. So yeah. I mean, people laugh, right? Right, but you qualify it, right? Right? So basically, he is qualifying and explaining, right, that he is not going to let anything happen that he does not want to happen.
I'm going to try my best. But,
Exactly, yeah. How about the rest of you? There were like 4 others who had their hands raised. Yeah.
So you tell them that all surgeries are done with two people assisting each other, and that the resident will be assisting the procedure, but also explicitly to the exact details of what the resident does.
And again, I apologize for putting you on the spot, but do you mind telling us why you don't go into specific details?
I don't think those are details that the patient would really understand in terms of the dissection of what the critical part really means to them. I mean, most people are more concerned about how the wound looks, who's closing the skin, than the details of the operation.
Okay, so there's a patient education piece. Yeah, Janie.
I've had patients ask me specifically, well, who's going to be holding the scissors? And I tell them, my resident will be holding the scissors because I'll be holding the tissues and telling them where to cut.
Mm-hmm.
And I mean, that's usually the case. So it depends, but when they say, who's going to be doing the operation, I say, we're both doing it because I have 4 holes in your belly and I only have 2 hands. So, in order to do this operation, it takes 4 hands. And so, we'll be doing, and I said, which side of the table I'm standing on at the time depends on how good the resident is and what a good job they're doing. And
Now,
I'm very clear that, it has to take 2 people, that you can't do it alone.
right. But I would just point out, now Janie and I are old friends. We go back a while. So I'm going to push a little bit on what she said, right? So telling the resident where to cut is not autonomy, right? That's essentially, I think as one of the residents pointed out, that's just, basically guiding them, right? Anybody could do that part.
I didn't say I give autonomy.
Right? No, you guys laugh, right? But that is very honest, right? In that a lot of us as attendings, we think we are giving residents autonomy by letting them do stuff, right? But that's actually not autonomy at all. Anybody have any other comments? Yeah.
So it's really interesting. I started my training much at the time as Dr. Spade over there. And at that point in time, as a nation, we had said that poor people and veterans got a lower standard of care because we operated with 100% autonomy on poor people and veterans. And I would say over the last 30 plus years, our social thinking on this has really changed to the point where when I became an attending, which happened to be in one of the largest public hospitals in the United States, and I realized it was my name on the bottom line, I actually had a crisis of how in the world could I let this poor person get a lower standard of care than when I walked across the street and did it in the private cancer hospital. And this is the part that we don't discuss, that we've evolved. And so I can tell you at the VA, none of that happens with what you're allowed to give autonomy for anymore, because we were outlawed to give autonomy. And an attending physician has to be present for every single timeout. And there no longer is the list of operations that the resident could do unsupervised when you were at home, which we used to have. But there is a social question here of trust, of responsibility, and the fact that we were trained on the back of the poor.
And I would go even further than that, right? I would argue this duality, this idea of a second class of patients that are okay for residents to practice on, essentially, right? I think we have pushed back so hard against that, right, and that we feel like we have to take over everything as the attending surgeon. And the resident is now left with no opportunities for autonomy at all, right? And it creates a really, really bad system, right? Because I don't know if you guys want to answer this question or not, right? But there are times, right, where we give the residents autonomy in an operation, right? And maybe we have them help us with a decision or something like that, right, as was pointed out. It may not actually be doing the actual procedure, and we regret it, right? Something happens, and, 2 liters of blood later, we're sitting there thinking to ourselves, I'm never going to do that again, right? And we almost developed this PTSD type relationship with resident autonomy, where, we basically judge all future residents against this one bad experience, this index case in our mind that just went so badly, we're never going to let a resident do that part again, right? Yeah.
I just wanted to respond as the Valley attending, only one here. I think there are a few things at play. I think that on the one hand, a lot of times when you have when we have poor patients, there is definitely less of a risk that they will sue you, which I think is definitely one of the aspects that we worry about. I think many other people, you worry a little more about that. I think the population we serve worries, we worry a little less about that. I think that, at the Valley we have a lot of acute care surgery, which means people are coming to the ED, they're having trauma or acute care surgery, and a lot of times the first person they meet is the resident, the second person they meet is the senior resident, and so, they don't mind getting operated on by the residents because those are the people they met originally.
They don't have any choice.
You can actually ask them, would you rather have a board certified, experienced person or this person?
Yeah.
I would guess they pick.
So I'm going to interrupt you guys just in 1 minute, right? Because I can see this going in several different directions, and we're not going to get out of here until like 9. So I just want to move on because we are going to come back to this point, okay? So if you look at studies that have been done that specifically look at how attending surgeons decide in real time how much autonomy to give a resident in an operation, you can see they basically came up with the mnemonic PICS. P stands for performance, as in how comfortable are I with the resident's previous performances. Impression, what is my impression of the resident? Characteristics, what are their training level, prior experience? Knowledge, does this resident's knowledge and operative plan jive with mine? And the situation, do I need to speed up this case, right? How many other cases do I have today? What's the current complexity of this operation? And what you can see is that the resident actually has very little control over any of these factors other than their relationship with the attending, right? And how well they prepared before the operation. But we also know that as clinical care teams have consolidated and become more efficient, the average resident now is on teams that are humongous, right? And they basically work with each individual attending less and less on the average rotation. And so it really becomes difficult for them to really establish that relationship up front. The other problem is that you would argue, even though they see each attending less, if we as attendings within the same team trusted our colleagues, we would say, oh, it's okay, longitudinally, we have confidence in this resident, and even though you've never done a hernia with me, I'm going to let you do the whole case. But we also know as attending surgeons, we basically have a failure to fail within our residency system. And we have a broken assessment system, right? The average assessment instruments used in a residency program are not valid and they're not reliable. And therefore, we don't trust it. And because we don't trust it, we end up basically with poor assessment, which I think the major learning point I would like you to get out of this part is that poor assessment is a patient care problem. Okay? It's not an education problem. It's a patient care problem. And because of that, we now end up with decreased autonomy. I was going to share with you one of these, walking 20 miles in a snowstorm up and down a hill, but for the sake of time, we'll move on. And now we'll look at the external regulations. So there have been a flurry of studies that have basically looked at the effect of resident participation on patient postoperative outcomes. And as you can see, most of them use very large surgical databases like NSQIP. And what they have shown is basically resident involvement in an operation basically results in either equivalent mortality or decreased mortality compared to cases done without residents. But they have a higher complication rate, higher surgical site infection rate, and longer OR time. I would argue the reason these results are a little mixed is that I'm not sure these large databases are the best way to do education studies because they were never really set up for that purpose. And I would also point out that although we all agree when residents do cases it takes longer, in fact one study found basically it costs about an extra $500,000 a year for residents because of extra OR time and staffing. But I would point out the federal government does pay over $10 billion for hospital-based GME, which is supposed to account for these inefficiencies. So I wouldn't let increased OR time be your argument, but again, it's sometimes a tough sell to make to the administrators. How about the American Board of Surgery? And I fully recognize Dr. Hahn is a director of the American Board of Surgery, so I'm saying this in a very friendly way and to please not make me recertify now as a result of this comment. But yeah, as I just, want to throw that out there. The American Board of Surgery does not really have much about resident autonomy, right? It says that the graduating resident has to do at least 850 operative procedures as operating surgeon, but it does not actually define what that means, and at least 25 cases as teaching assistant, which would imply they have a fair amount of autonomy, right, in doing that. And at least 6 operative performance assessments, but again, there's no minimum score that's stated. What about SCORE? Well, SCORE shows about 132 core general surgery operations, right? It is an impressive list of operations. And again, this is what we base all our curricula around. This is what we base all of our assessments on, right? The American Board of Surgery qualifying and certifying exam are based on SCORE. But is this realistic, right? Does the average general surgeon, either in private practice or in an academic medical center, really do 132 core operations? Okay? And then you look at the ACGME, right? And we are all kind of painfully aware of the core competencies at this point, created in 1999. But as you know, one of the issues was that there were no real framework about how to use this and specifically how to find assessment instruments around these. So they then created the Milestones Project with the Residency Review Committee in Surgery, and they set up 17 milestones in 8 practice domains. And what you see is that there are 4 levels, right? Level 1 is incoming resident. Level 2 is the resident's advancing. Level 3 is kind of like a mid-level resident and is, doing well. And level 4, the resident is advanced, so now that he or she has demonstrated the milestones targeted for the residency, right? But they make it very clear that level 4 is a graduation target, not a requirement, okay, in order to finish the program. But out of the 17 general surgery milestones, there is only 1 that talks about resident autonomy. And I just want to read it for you so you guys see the language. Level 3, so mid-level resident, this resident demonstrates proficiency in the handling of most instruments and exhibits efficiency of motion during procedures. This resident moves through the steps of most operations without much coaching and is making intraoperative decisions. The resident performs many of the core operations and is beginning to gain experience in the advanced ones. It's a little vague, right? But it would argue that actually the resident has to demonstrate a fair amount of autonomy at the midpoint of residency just to make this level 3, right? Because by level 4, they're basically doing all of it. It's all independent work. Finally, let's talk about the patient point of view, which I think honestly is the most important. And I think this is probably one of my favorite papers on this topic. So they surveyed the general public and asked them, would you like resident participation in your care? Kind of like similar to the question you guys were asking, right? 82%, so 96% of them agreed that the residents should participate in their care. 82% said for a basic surgical procedure, and only 59% said for a complex surgical procedure. But when asked if you needed a routine procedure, would you consent for a resident in the final year of training? They even spelled it out. 4 years college, 4 years med school, 5 years of surgery residency. Would you allow them to perform your procedure independently? So just shout them out. What percent of patients agree to that idea? 0. 3, I see. It's like Price is Right. Anything else? 30%. 30%? 10. Do I hear higher? 50. 73%. I was floored. Yeah.
But is that the right question? The right question is, would you want that, or would you want an attending surgery?
Right, and we will get to that. We will actually get to that, okay? But still, I mean, 73%, I mean, that's pretty impressive. Certainly a lot higher than I would have guessed, right? And then they said, well, if I have surgery, I want to know how much of the procedure is going to be done by the resident. 61%. All right? So they want to be very involved in this decision making. And so the end result of all of this kind of looking at all these perspectives was that we decided to restructure the autonomy within our residency program. And Tiffany went through that. Yeah?
Because the military, I think it was Madigan, did a very similar study where they actually said what the goals were by, they described what a resident was, what this was. And I thought they showed very different results than what you just showed, where basically people said no, they actually didn't want these things.
Right. I think if it's the study you're referring to, this was a study of veterans.
Air Force Base.
Yeah, and this was veterans.
No,
Was it not?
No, it was active duty, so it's families, young people, etc.
Of the military.
It was at DOD hospital.
Yeah. So again, I completely agree with you. I mean, it's a different population, right? But absolutely, right? Different populations may feel very differently about this. And certainly the population here may feel very differently about this, than anywhere else. But basically, so what we did was we created this resident autonomy service, and it emphasized a lot of the things that we've been talking about today, right? The interoperative decision-making, entrustment, valid and reliable assessment and feedback, and this educational scaffolding. But the key here is that we did not actually have a budget to do any of this stuff. So we had to kind of improvise as we went along. And keeping these frames in mind, we created what's called the Baker Team 7 service. And the Team 7, as Tiffany will tell you, it's not a code. It's just that we already had 6 other teams. And so the newest team was called Team 7, right? And as you can see, the residents got quite creative, right? I don't have Tiffany's ones here, but basically some of them were very nostalgic, right? They said in the spirit of Edward Churchill. Some of them said, a chance to cut is a chance to cure when you need steel to heal. And some of them were kind of funny. Stool is cool, but appendixes and gallbladders are okay too. And basically handed these out to the emergency department, the internal medicine residents, wherever they thought they could find business, right? And, handed out their pager numbers and really, I think, went all out in trying to find patients. And interestingly, the way this was structured is a couple things. So going back to the facets, right? From a medical student point of view, we did not allow medical students to rotate on Team 7 because we felt that, honestly, the chief resident has got a lot going on trying to lead the operation. And honestly, a lot of the operations are happening kind of later in the afternoon and evening. And so probably the medical student wouldn't be around. From the resident point of view, we really gave them kind of free rein to find cases wherever they could, and also some flexibility in the work hour restrictions because of that. From the attending point of view, we all agreed that the residents could choose which attendings they wanted to staff the patients with, so you didn't have to participate if you didn't want to, number one. Number two, the residents had their own block time. So when the residents schedule procedures, this would not basically take up your time as the surgeon. Their OR time would also not count against yours, right? So there was completely separate historical operating room times. From an external regulation point of view, again, you had to meet all billing criteria. You had to be present for the critical portion again. And then from a patient care point of view, you had to explicitly tell the patients what the resident was going to be doing, right? And a lot of attendings had a lot of difficulty with this part, okay? It was very difficult sometimes for attendings to feel comfortable saying exactly what the residents were going to be doing. So then we basically decided to study this, okay? You have a PGY5 and you got a PGY3. The PGY3 also runs a lumps and bumps clinic, okay, on Mondays, and that was our first study. So the lumps and bumps clinic, I think you guys probably have the same thing here, but basically the PGY3 then is doing procedures under local anesthesia. Soft tissue mass excision up to 12 centimeters, scalp mass excision, skin lesion excision, IND abscesses, and abdominal fat pad biopsies for amyloidosis. Okay, those were the main core procedures that the PGY3 was doing. And basically, I had a lumps and bumps clinic that was running concurrently. Okay, so all the patients were staffed with me. So patient shows up with a lump. The resident, this is Brandon Wojcik, who led these studies, would evaluate the patient and then present them to me, right? This is the first hard stop, okay? So no procedures are going to be done until I see the patient and agree with the plan. Then the resident removes, okay, the mass or the lesion or what have you, and I come in and look at the wound prior to closure, right? Make sure everything looks good before they're done. And then the resident then talks to the patient, goes over the postoperative care, and sets up any further scheduling, okay? So, you know, it became almost like a cottage industry for the PGY3s. And what you see here then is they did about 110 procedures in the 10 months of the study. I did about 289. And there was no difference in patient population, okay, which is very important going back to that question earlier about these two groups. And also, you know, in general, the most common procedure was soft tissue mass, but I did drain more abscesses than they did to give them the kind of better educational experience, which I think you still owe me for later, but we'll talk about that. So basically, the only difference is that the resident patients probably were a little bit more difficult, right? So the odds are stacked a little bit against them because their patients are more obese and they have a higher Charleston comorbidity index. Then you look at our complication rate and our outcomes, and what you see is that there is no significant difference. At the time, this was the first study where a resident was doing the procedure essentially on their own to show no difference in outcomes, okay, at the PGY3 level. So then we decided to ask about satisfaction, and you're going to hear more about this study if you go to the education meetings. But basically, we asked the patients to complete the AHRQ Consumer Assessment of Healthcare Providers and Systems, or SCAPS, survey, and then again compared attending scores, me, and the resident scores. And what you can see is we had a really good response rate, English and Spanish versions. And the only significant difference in patient satisfaction was that in general, the resident patients had a little bit less satisfaction with was the procedure room comfortable and did the surgeon make you feel calm and relaxed, which is really interesting because we use the exact same procedure rooms. We're just bouncing back and forth to the same rooms. So there's no difference in the physical layout of the rooms. Rather, there is clearly a difference in the nuances of how to keep someone calm, right, while they're wide awake, okay? And it also shows where the education intervention can now come into play. Because although their composite scores were exactly the same, if you look at their individual scores, there are residents who scored significantly less than their peers, okay, for both quality of care and pain. So now we're trying to figure out basically how to give this information as a quality improvement project, right, in real time, so that residents can improve their overall performance. And then we also did the inpatients. The inpatients ended up being from September 2014 to June of 2015. And it was a control cohort study of 3 most common abdominal operations that were done by this Team 7. and matched by attending and procedure. And we looked at the outcomes that you can see here, and basically found no significant difference, okay, between the patients, which again is very important, especially when it comes to both ethnicity and insurance status. Again, the deck was a little bit stacked against the residents rather, because the resident patients tend to have a little bit higher incidence of diabetes and a little bit higher rate of non-elective cases and dirtier wounds, because their cases tend to be more emergent. And as you can see, there is no significant difference in their outcomes for laparoscopic appendectomy, laparoscopic cholecystectomy, and open chole. However, the length of stay is more for the residents, and the operation is about 22 minutes longer when the residents do it versus when the attendings do it with a resident. Okay. We then surveyed all of the residents a year after they either were in independent practice or they were in fellowship, and asked them how did the Team 7 service compare to all their other chief level rotations. And as you can see, the results are very encouraging, where they really felt that it helped increase their transition to fellowship or independent practice and increase their confidence and overall autonomy. Now, the future of Team 7, just to be honest with all of you, is questionable. And the reason is it was always set up as a pilot project, number one. But number two, our surgical volume fluctuates. And what we have seen is that some surgery residents or chief residents are hungrier than others. Okay? So some do more than others. Interestingly, though, what we have seen, and we're very happy about this, is it has sparked a lot of friendly competition among the other surgical services. So our emergency surgery service now lets the residents do a lot more in the operating room, as well as transplant and thoracic, which is really nice to see. And we also now are focusing on this idea of how to better prepare the residents coming into the operating room. So we've been really boosting our simulation-based training, specifically looking at video-based education, and also incorporating more surgery attendings in the simulation-based training instead of simulation specialists. And again, our simulation specialists are awesome, but what we've noticed is that if the surgeon actually works with them practicing, say, bowel anastomosis in the simulation center, they're more inclined to give that resident more autonomy in an actual bowel anastomosis because they already have that relationship together, which makes sense based on what we've talked about today. Now, I don't want you guys to think that you have to basically restructure your entire residency program to give more autonomy. This interesting study basically came out that showed that residents who discussed the case the day before surgery with their attending were twice as likely to rate themselves as surgeon or teacher when controlling for PGY year. So it's a very easy thing on the resident side to do, is just establish that relationship, establish the communication up front, and go over the goals. So next steps, in my opinion, again, could be totally wrong about this, but if I had a crystal ball, I would argue the next steps then are going to be about faculty development, right? And we really need, I think, as a whole, as a profession, to really see faculty development in education as just a common routine thing, as same as we would do continuing professional development in any other piece of being a surgeon. And as you guys know, entrustable professional activities are coming. It's going to be interesting once they arrive, but I know you guys are working on that. And I think it's going to lead to a redefinition of what are the core operations for a general surgeon, and hopefully a greater focus on really what is our final product, right? What are we trying to produce at the end of a general surgery residency? And maybe even more modular training like they do in Europe, therefore. So in summary, and again, I apologize for running a little long, but I think resident autonomy, obviously a very important part of the educational experience, and although there's a lot of competing perspectives on it, I would argue that our work has demonstrated that structured resident autonomy is safe with comparable outcomes, but requires a ton of planning, okay, and work. And I think also, I would argue maybe independent practice should not be our goal for the end of residency training, except for those few people who really will be completely independently practicing. I think for the rest, we may be shooting for supervised practice, right? And at least set up our assessment instruments accordingly. I just want to take a few minutes to thank all of our team. I'm blessed to work with an amazing education research team. We have amazing faculty, amazing fellows and students. But obviously, none of this would be possible without leadership from my division chief, Dr. David Ratner, my mentor and section chief, Dr. Richard Hoden, and of course, Dr. Keith Lilimo's leadership and support in the educational space has been phenomenal. So I just want to give a shout out to all of them. Thank you very much, and I look forward to your questions. Dr. Hahn.
So, Roy, thank you very much. That was a great talk, and I think it really tees us up for, a lot of the things that we'll be working on, and we will be in the pilot for entrustable professional activities, and I think there'll be a lot of faculty development that will come along with that, but it really is trying to break down those steps that are critical for basic routine general surgery problems, and having the resident be able to show their graded autonomy in those steps. So I think the board is working with Surgery RRC and ACGME to figure out how can we, at least for those things that we think are so core and that we see enough that we can repeatedly measure over time, that we can document that kind of transition towards competence.
Absolutely.
I mean, I think it's really great to set it up. So my question for you
Sure.
is, when you're with your pilot study for your Team 7, for billing you had to have some supervision.
Correct.
So there's never complete autonomy. And tell me about what that supervision was like and what the variability of it was like.
Right, so for each operation, the attending surgeon had to basically let the resident know what they felt was the critical portion, right, of that operation that they had to be there for, right? So for example, if Tiffany was doing a laparoscopic cholecystectomy with a PGY3, she could choose to either be the operating surgeon, the teaching assistant, what have you, but I said, before you clip anything, I want to be there. Right, and it was very clear, right? And to be honest with you, a lot of the training actually was with the OR nurses, scrub techs, and the anesthesiologists, right? Because you had to get their buy-in that A, this was going to take longer, and B, to call if they suspect anything is amiss, right? Because this is not about, again, I trained in a VA as well. This is not about us inventing new operations, right? And flailing around and, just trying our best type of thing, right? This is about doing safe, standardized operations. And I think keeping that communication open was really, really important to everybody. Jim.
Roy, great talk.
Oh, thank you.
One of the areas I think that seems to be missing a little bit as far as the pressures are concerned, I think it really goes back to that. There's really two types of autonomy, right? There's the knowledge autonomy, and then there's the technical autonomy. And I think that's the thing about what the board does. It's like it gets that knowledge autonomy. So individuals are okay with their knowledge to do certain things. Doesn't mean they can technically do it.
Correct.
And the reason why I bring that up is one of the other pressures that it seems to occur is, as you notice, the medical students aren't doing as much, so it gets pushed forward. But it's also been pushed down that nobody really thinks about. And what I mean by that is you've got 80% of the individuals leaving residency today or fellowship go into a model where they're in employed positions. And in the past, when some of the people that were older than me, you went into a practice with individuals that continue to hone your skill as you went along. And that's where I think we're losing things, because that's not expected anymore of the individuals that are out there, nor is it expected by the individuals that are coming out. And so is that one of the areas where we can try and focus on as well to continue to develop that autonomy? I don't know that any of us were totally autonomous when we finished residency, do anything and everything.
Yeah, I completely agree with you. I mean, you take me, for example, right? I do a lot of laparoscopic cholecystectomies, right? But at the same time, if a resident is doing one and accidentally puts the Maryland straight through the middle of the liver, I haven't done real liver surgery since I was a resident, right? And I'm going to have to call in help to fix any significant damage to the liver, okay? And I think you could argue, right, well then that means you shouldn't do laparoscopic cholecystectomies unless you can take care of every single possible complication that could possibly occur. But I would argue that's not the actual, I completely agree with you, this is not the environment that most people practice in, right? Most of us have someone who we can consult if we get into trouble, right, that have a specific expertise in whatever it is that we're looking for. And we can manage, in the meantime, certainly we can at least get the bleeding under control, pack, weight, that sort of thing. But I would argue that we're right now at a little bit of a disconnect. And maybe that's because, again, our external regulations have not kept up with the pace of training. Again, that's just my bias. Yeah.
2 points. One is, I think the decline in autonomy of residency is not as steep as we always think of it. I think it's related to we all walked uphill in the snow to school both ways.
Don't forget the killer mountain goat.
Yeah.
Yep.
The other thing is, I think the stress of the N of 1, that bad complication you have when maybe you weren't exactly observing, so that they cut a piece of bowel or closure of the fascia, which is, very appropriately 3, 2, 3, 4, 5 level case to close the bowel. But if they catch bowel and you have to go defend that at your peer review committee, and because it happened because you weren't there to observe it, and that patient goes back to the operating room and is sick in the hospital for several more days, is that N of 1 is so powerful, I think, and that's the struggle, the stress I think attendings feel quite a bit.
Absolutely. Yeah, and so my approach, and I'm not saying this works for everybody, but I think a lot about taking a beta blocker before I operate with a resident, number 1. Number 2, I do a lot of counting underneath my breath, right? But I'm really just watching the time, right? And I'm more than happy to let a resident struggle a little bit, but I'm not there to let them struggle for an hour, right? Especially if I see them doing things that are dangerous. And I've learned over the years, and I'm not saying this works for you all, but maybe it's not about doing the entire operation from skin to skin, right, autonomously. Maybe it's talking to the resident ahead of time saying, what part do you really want to work on? What part do you really want some feedback on? And then I kind of help them get to that part, so we have a lot of time to let them struggle. And then I just sit there and watch them, right? And I'm basically very, very not so helpful. Right? I'm holding retractors wrong. I'm, not really giving them much exposure. The light's wrong. All these things that they have to think about, right? For a senior level resident, But at the same time, it has to be appropriate, right? So if they're not getting it, I have to feel comfortable then at the end of the day debriefing with that resident and being like, look, you really have to work on this. And I would argue we as surgeons, we're not really trained to give feedback that way, right? I mean, we want to be liked by our residents. We don't want to tell them these things that sometimes are very true, but can come across as hurtful. And I think it really, again, hampers our ability then to allow that resident to continue to get more and more autonomy, because then they just go on to the next attending, right, and continue to make the same mistakes. So, oh yeah, sir.
Yeah, so thanks. You hit like on 3 of my major pet peeves about the autonomy talk. So one is, some of it's dependent on the resident. You have to come to the OR prepared.
Right.
There's a few things that already make me mad, but just, showing up unprepared and feeling entitled to do an operation is not really acceptable, right? That's 1. 2, most of the talk about autonomy quickly degenerates into, well, we'll let the, P2I5 take call and do non-elective cases, and that's really not right. Like, you're taking the vulnerable patient population and using them as the fodder for resident autonomy. And then the third thing, which is what you hit on at the end, is that none of this discussion, so you talked about, really just talked about, the whole environment has changed, the whole educational environment has changed. What do I, as an educator, need to do differently in 2018 to teach residents independence and autonomy? Because we can't go back to the way we did things 20 years ago.
Exactly.
So that whole idea of faculty development, what do we as faculty need to be doing differently now to prepare our residents? No one's talking about that. And that's really what we have to do, because we're not going to go back to the old system of 20 years ago.
Right. Absolutely. And the other thing that I would mention in that faculty development piece is this idea of implicit bias training. So I honestly didn't realize that there were times, and this goes back to your comment, that I would just, subtly basically take parts of the operation away from a resident. And you guys know as attending surgeons, that's not hard to do, right? You can easily move your hand to all of a sudden now the resident does not have an angle, right, and can't throw the stitch, right? And so all of a sudden you're like, oh, I think I have the better exposure. Why don't I do this part, right? So you can do all these little tricks, right, and mind games, but it's not helpful, right? And what it is really is me, right? It's my thinking that I had something really bad happen at this part, and now I don't really want to let any resident do it. And I'll be honest with you, it's hard to look in the mirror when that happens, you know, and really face, you know, and honestly, right, like why did that mistake happen, right? Was it because you weren't there, or was it because you were thinking about something else, you know, at the time, or what have you? Yeah, Janie, I'm sorry.
Roy, I think the most important thing that you're pointing out now is that autonomy can occur with the attending in the room. And that the key for me, for patient safety, is for me to be there, but to bite my lip and let the resident make the mistakes. And that's really, I think that's the safest autonomy that we can provide, or that I can provide as a teacher. And then I agree, we need to get better at giving feedback and telling residents things they don't want to hear. And I think that those are the two things that, you know, that are really important to remember. When autonomy doesn't mean you have to stay at home.
Right.
It means you have to bite your lip and you know, help the resident learn.
Right, and I will argue that I think because of all this investment we've done in simulation training, that biting the lip part doesn't take so long and is not so painful. Because generally now the residents can do it, right, before they get to the OR, which is super helpful, you know, and honestly a lot less anxiety provoking on the attending side.
Thank you, Roy.
I think we have, it's been thoughtful that we still have a lot of work to do to define autonomy. We've talked about the cognitive aspect of autonomy. I think we tend to push more on the side of technical. And this makes me thoughtful. Faculty walk around with comparisons and expectations of residents in their head. And I don't know, I mean, I want to ask here, I'm new here, how many of the residents in the room have you seen a video of your resident in your year that a faculty thinks that's gotten the highest ratings? I mean, are you all able to compare what you do? Do you really know what the difference between your skill and ability is compared to your peers in your year? No. We all do. So they have really high expectations, and then when a faculty says ICMs, they take the picture, you don't know that their experience with another resident is different.
Yeah, interesting side effect of the Team 7 real quick is this idea of double scrubbing chief residents. So we have seen this actually in a couple times evolve where the other chief residents like to scrub with each other just as a check-in to see how they compare against their peers. And I think it's a great idea to just think about.
I think faculty should do it watching and teaching as well.
Absolutely.
Okay. Thank you for the discussion. And
Sorry to go over.
Roy coming. Roy's going to be at the cadaver labs that we're doing today with the residents. So if the residents want to talk to them, turn them on to you. And again, thank you for coming.
No, thank you guys so much.